Good morning, everyone. My name is Stephanie Romano. I'm the Education Coordinator for the SWORBHP Hospital. Thank you for joining us again on another educational adventure as we take this one on today. We're going to do something a little differently. So for those of you who have joined us before, you're used to sort of our webinar presentation style where we do a PowerPoint in the background. Today we've opted to do something a little different. So we're going to have more of a podcast or a radio chat today on hydrogen sulfide. So you're going to hear our three presenters speaking, but you're not actually going to see any PowerPoint slides changing. So you'll see right now just the topic on one PowerPoint slide with our three presenters, a picture of them, their names and their designations. But again, you're not going to see us switch slides. So it's not a slideshow presentation. Again, more of a radio chat or a podcast if you're familiar with that term. And so as I said, today's discussion is on hydrogen sulfide. And our presenters are Dr. Mike Peddle, who's our interim local medical director here at SWORBHP. We also have Josh Denning, the operations superintendent at Middlesex London EMS, and Chris Champagne, a platoon training instructor for the London Fire Department. As we do with other webinars, you will have the opportunity to ask questions either throughout the presentation or at the end of the presentation. If you'd like to ask any throughout the presentation, then feel free to type them into the question box at the bottom of your control panel. And I will either bring those up live or I'll bring them to the panel and they can answer them live that way. At the end of the presentation, if you do have a microphone and you'd like to speak live, you can throw your hand up using the hand icon on your control panel, and I can unmute you at that time and you can ask your question live. Otherwise, feel free to type them in the question box throughout the presentation and I'll present them to our panel. And so without further ado, I'd like to present Mike, Josh, and Chris and discussion on hydrogen sulfide.
Thanks, Steph, and that's exactly it. We're trying something new here this morning. Going to do more of the radio show approach to discuss hydrogen sulfide. Joined by Chris Champagne, who's the platoon training instructor at London Fire and one of the hazmat people, and then Josh Denning, operations superintendent with Middlesex London. What we're hoping to cover today is basically to look at hydrogen sulfide. We want to talk a bit about first responder recognition, so how to recognize it and be safe, and some scene safety stuff. We're going to talk a bit about PPE for the responders and responder roles, talk a bit about decon, and finally some of the patient management both at the scene and then on transport to the hospital. So a little bit of background on hydrogen sulfide. So hydrogen sulfide, or sometimes called swamp gas, is a toxic gas and colorless, so you're not going to see it necessarily. Most commonly seen with the petroleum industries, but is also a product of natural decay, and has that standard, rotten egg smell that everybody is probably well aware of. It is bad, and it exerts its effects in a couple of different ways. One, it's a moderately soluble irritant gas, which means it's going to irritate things, starting with your mucous membranes, eyes, as well as your upper airways and lower airways right out to the alveoli. And so that is a sort of a initial effect you can notice, and then it can have some prolonged effects that do impact medical care later on down the road. More importantly, though, and its biggest problem is it is a cellular asphyxiant, and what that means is it basically prevents the cells from utilizing oxygen. Similar to cyanide, it binds the cytochrome oxidase chain and thus prevents the cell from producing energy. And if the cells can't produce energy, they can't work, and if cells don't work, then neither do you. So those are the two big effects, and the big one, or the most important one, obviously, is that cellular asphyxiant and how we deal with that. It starts, from when you look at concentrations and how it works, it can start as simple as, at 50 to 100 parts per million, it acts as an irritant. So you'll notice it, you'll smell it, and you'll have some irritant effects to it. At 150 parts per million, you actually get olfactory paralysis. So all of a sudden, once it hits 150 parts per million, you'll get that initial smell, and then you won't smell it anymore. So that's a pretty important thing, and we'll talk a bit more about it, is that once it's reached that point, you actually won't smell it anymore if you're a responder. So it's not a great or perfect indicator for you. Anything over about 1,000 parts per million can result in what we call a knockdown phenomena, where it only takes a couple of breaths and you'll go unconscious and it'll be rapidly fatal. So that's an important number to think about when you look at some of the studies done with how this is made in enclosed spaces. And with reasonable amounts of precursor, it's not unrealistic to expect 6,000 to 8,000 parts per million in an enclosed space within a couple of minutes. So these are pretty impressive numbers when you think about it. It doesn't take a lot to have significant effect on your first responders. So moving in that venue, Josh, do you want to just take a little bit on the responder recognition and sort of thoughts that you have from an EMS perspective?
Sure, thanks, Mike. So a lot of times when we get these calls, we are either going to be very lucky and know what we're heading to, or we're going to have absolutely no idea, and that's where it's important for us to try and recognize some signs to keep ourselves safe. Mike mentioned the smell. That's likely the first thing that would be noticeable. It's like a rotten egg or an almond smell. And a lot of times when we get these calls, it's going to come in as a welfare check or an unconscious or a VSA patient in an apartment or in a car. And I think we've probably all walked up to a car with somebody in it, opened the door to assess them, and that's where the real danger lies with this stuff, whether it's in a car or an apartment. You know, as Mike mentioned, if the parts per million are high enough, you open that door, and if you've got 4 or 6 people standing around, there's really the potential there for those responders to be harmed pretty quickly by it. In a lot of cases we've seen in the past, people have been considerate enough to leave a note, a very clear note that states that they've attempted suicide with hydrogen sulfide. And if that's the case, then it's obviously simple enough for us to notice that and take the appropriate precautions. But in the cases where they haven't done that, it's really up to the responders to protect themselves and each other. And I think what that really comes down to is slow down, take your time, take in your surroundings, and do a full assessment of your scene before either opening any car doors or apartments. And this, of course, applies to all responders, not just to EMS. Just take that extra few seconds and just be aware of what you're about to walk into to the best of your ability.
Yeah. Kind of comes back to the MCAPE that they teach in college, eh?
Exactly.
Exactly. Well, and one of the things that they talk about, and when you see some of the pictures of these scenes, I agree, the sign is one of those things that we hope for, I guess, as first responders. We hope that there's a sign, but in the absence of the sign, I guess things like buckets tend to be quite common as a mixing tool, or numerous sort of jugs or barrels or stuff stuck in the car at some point. So if you see that, I think that would be one thing that would make you sort of say, hold on, maybe there's something else going on here. Chris, any thoughts on other things that would help people recognize that maybe this is what's going on?
Sometimes, Mike, they will duct tape the windows closed to try and get a better seal to keep the gas inside the vehicle from parking, whatever. So again, if you see vents duct taped or taped over, windows taped shut, that might be another clue that they're trying to keep the stuff in and trying to
increase that concentration.
Increase the concentration, exactly.
Okay, so we've had our first question already of the day. One of the things is that, so if this is done in a car where they've sealed it up, I guess, would you smell the smell of rotten eggs walking up to the car?
You might. Again, it's how tight can you seal the car, right?
Right.
If there might be some leaking out, you might smell it, you might not, depending on how good a job they've done at sealing up, what the concentration is. How long have they been sitting there? Has the gas dissipated over time, or is it something they just mixed up and you just happened to walk in on it right as they were doing it? Okay,
so potentially we could smell it.
But it's not always it's not a surefire indicator.
Exactly, and I guess and the other thing with that is that risk of once you clear that 150 parts per million, you might get the first whiff of it, but then you don't smell it anymore because of olfactory paralysis, and that's not I thought I smell it and now I don't, everything's okay. It could actually mean that it's still at a level that could be harmful to you.
I think as well, approaching a car, we have the benefit of being able to see what's going on in there as opposed to an apartment or a house. that's where it is really important to, if it's nighttime, get your flashlight out, have a look before you open the door, and look for the things Mike mentioned, like the buckets and the chemicals. And that is a benefit for sure to be able to see what's going on in there.
Mm-hmm. And I guess coming back to one of the things Chris said, if you're in a house where if you're duct taping the doors, trying to seal it and stuff like that, if you meet resistance to the doors with a potential of smell, that may be one of those signs that you want to at least consider what's going on and ask for help at that time.
Or if you all of a sudden, as you try to, for someone to force the door, and you get a whiff of that stuff, that's time to stop, back up. This isn't just a run-of-the-mill unconscious patient anymore. We need to treat. Basically, it's a hazmat call now. Exactly,
and that rolls right nicely into acceptable PPE for these events and stuff like that. So if we're on scene, EMS arrives on scene, we'll take the car to start as an example, because they tend to be a common example, and they see the taped windows or the sign there. Calling hazmat is obviously the first thing they should do. When you guys come, what's going to happen then, Chris?
Well, we're going to put our full bumpy ground with SCBA. Respiratory protection is the big thing with hydrogen sulfide. It's not, in higher levels, it can be a little bit of a skin absorption, but its main route of entry is inhalation.
Okay.
So we want to protect that route. So we're dealing with an unknown concentration, and until we figure out an unknown chemical and an unknown concentration. So we're going to default to self-contained breathing apparatus and go that way. We're going to assess what's going on, take a look around the car. Like you said, we're going to take our 4-gas monitor off. Every fire truck in the city has a 4-gas monitor that does detect hydrogen sulfide, so we'll take that off. We'll see if we're getting any readings around the car and that sort of thing, and then we'll proceed from there.
Okay. Now, one of the things that I'd heard is it's a flammable gas, or when I've read it, it is a flammable gas, and that does change how you approach a car, even from an EMS perspective. But do you want to talk a bit about that, Chris?
Yes, hydrogen sulfide does have a flammable range. It is approximately 4% to 45%. So it first becomes flammable at 4% in air, and after that, it stays flammable until 45%, which is a lot wider than even natural gas. Natural gas by itself is 5 to 15% roughly, so this has a lot wider range. It stays flammable for a longer time. That potential's there. If you get some kind of spark and you've got the proper concentration, you could have an explosion also.
Okay. So do they recommend then, if you're going to approach a car with this, that instead of opening doors initially, you should ventilate the car, like break a window or something?
Break a window. What's the first thing when you open a car door? What happens?
The light comes
on.
on.
The light comes on, and you hear the ding, ding, ding from the computer. Last time I checked, they don't put explosion-proof lights in the tops of cars, so there's a potential for a spark there. And again, we don't know the concentration.
Exactly.
Is it likely to be there? No, but you don't want to be the first guy to prove the point. Oh, yes, it can reach explosive levels. I just found out the hard way.
Exactly, as you wake
so
up on the
it's always
other side.
best to break a window first, let it ventilate out, and then proceed from there.
Excellent. Okay. And now, I guess the other thing with this is not all places have hazmat teams that are going to be able to respond to these events. Some of these are going to occur outside of major centers. So from a rural fire response, what would be some of the things that they should consider do and when they are, approached with one of these events?
Again, it's the same thing. They should at least have a 4-gas monitor, and that's almost anymore. That's almost the basic requirement for fire department to have a 4-gas monitor that should detect hydrogen sulfide. And most 4-gas monitors, when you buy them off the shelf, it's oxygen, flammability, hydrogen sulfide, and carbon monoxide.
Okay.
So it would serve you. It has lots of other uses for a fire department, but again, the hydrogen sulfide. So again, you come up. Every fire department should have SCBA. Come up, do your assessment. SCBA and bunker gear will give you enough protection to do your initial scene assessment.
Yep.
And from anything coming up from gas that way, it's the respiratory protection you're concerned about. You can puncture a window using a pipe hole or something, let it ventilate, check the levels again. When it gets into actually handling the body or a contaminated individual, depending on if they've gotten some of the precursor chemicals on them, you might need some other higher level of chemical protection, just because they're corrosive and that sort of thing.
Right. Now, when it comes to, and this is a discussion between fire and EMS. So in the event that we get one of these calls, you open up the window, you suspect that the patient at this point needs to be managed. So it sounds very reasonable that anybody in their bunker gear plus appropriate respiratory protection with SCBA can remove the individual from the car at that point.
It would depend. Again, you'd have to assess it. If they've got chemical splashed all over them, probably not a good idea.
Okay.
It could possibly become contaminated. Another option might be to put a salvage cover over them and handle them with that.
Okay.
And get them up on the ground that way.
Gotcha.
So you're not coming in contact with the actual chemical.
Okay.
And then get into decontamination at that point.
And decontamination. So why don't we talk a bit about decontamination, because that really should be the next step. So we'll make the assumption that we have a patient that at least has signs of life, so that we want to we want to try and treat the patient. To me, I mean, I would say that recognizing it is a gas, and most of the gas is not going to be on the patient, and once you remove their clothes, most of it should be gone.
Right.
I completely agree with you that my concern would be is if you're in a car trying to mix two chemicals, well, you may not have a lot on you. There's at least the potential that you're going to have some splash response on hands or somewhere else.
Or when it's reacting, because it's a violent reaction, it's giving off gases, it could be splashing out onto the person too.
Exactly. So reasonable decon, what would you expect from for this event?
Get their clothes off them. When you remove their clothes, you're going to remove 80% of the contaminant.
Okay.
After that, soap and water and a hose line, basically. And if you don't have soap and water, just gross decon with lots of water if that's all you got, that's all you've got.
Exactly.
Get them off, get them deconned off. You can check them after with your monitor again.
Yeah.
Once you decon, hold your monitor over them, and if they're still off gassing, you have to keep deconning them. Another problem is sometimes there'll be gas trapped in their lungs.
Mm-hmm.
So when you're intubating them or bag valve masking them, you have to take that into account too. But again, this will all be done again with firefighters on SCBA bunker gear. And again, if you have the other equipment available for higher level for handling the patient, it's highly recommended. Okay. Just because of the caustic nature of the ingredients.
Absolutely. Right. Well, we have a few more questions. I think first question here: should we be calling for a hazmat team? I think if there's one readily available, absolutely, sure. Would be my answer. Chris, would you agree?
Yes, I agree most definitely. They'll bring advanced air monitoring. They'll bring the proper personal protective equipment. That's the way to go.
I think from an EMS standpoint, as soon as you recognize that this stuff is present, then that's the time to back away, and that's when you need to get other people involved who have the expertise to handle it. Because as paramedics, I mean, we don't have the PPE to handle this stuff, and the fact that some of these people are going to still be alive when we get there really complicates it. Not to sound insensitive, but in the ones I've been involved with in the past, if it's a successful suicide, we have the ability to slow down and take our time and deal with these things, at a rate that's going to be a lot safer for everybody. When they're still alive, there's that urgency to help them. But despite that, we still have to slow down and make sure that we gather all the information we can and do everything we can to protect ourselves. And that means getting a hazmat team in there at the very quickly. And if there's no hazmat team available, then the fire department that's responding will at the very least be able to help with decontamination and protect themselves better than we as paramedics can.
Exactly. The one thing that we really want to get across today is that we really want to try and avoid one patient becoming more than one patient, which unfortunately has happened in previous events. A couple other questions that have come in talk about, one is the SpO2 being reliable or unreliable in H2S patients. It is and it isn't. The big thing with it is that it'll be unreassuringly high. Most of these patients will likely have a very high SpO2, so they'll sat very well. The problem is that they can't use that oxygen because cellularly the cells have been poisoned, so they won't actually be able to utilize the oxygen that's being transported. But that's a very good question.
Mike, can I just touch on that as well? We're starting shortly using new monitors where we're going to have the capability of monitoring end-tidal CO2. Would we see any variance with an end-tidal CO2 waveform with this type of poisoning?
That's a good question. I'll have to think about that one. Give me a minute and I'll ponder it as we continue our discussions. I suspect that, yeah, let me ponder that one and we'll come back to it.
Good, I stumped you.
All right, what else do we have here in the questions before we continue on? How much protection does an N95 actually provide in an H2S? It basically provides no protection for you in this perspective. Basically, N95 is a particulate, so it's the size of the particle that it will filter. So unfortunately, H2S is a gas, so it really provides no protection for you in an H2S poisoning. How much of H2S is being recorded using monitoring detection post-decon? So I guess, and maybe Chris can answer this, if they've been deconned and then we're checking them with the monitor, we're monitoring how much is still being produced by any chemicals on the patient.
Or if there's any off-gassing still going on, if there's any vapors trapped anywhere, that's what you're checking for. You're checking just to make sure that you've done a good job decontaminating. So basically you want 0 if you can get it. Just remember with hydrogen sulfide, the TWA, or time-weighted average exposure value, is 10 parts per million. So that's the magic number. Your monitor should alarm at anything above that number.
Okay. All right.
Is it reasonable, Chris, to expect after decon that there would be a pretty good chance of it being 0, or would we maybe expect to see a low count in parts per million that would still make it safe to deal with the person?
Again, it depends on what concentration they were in and how long they were there, right?
Right.
You could possibly, but again, if it's a gas, it's going to want to be a gas. It's going to want to not stay in one place on the body. It's going to want to form a gas and travel through the air, that sort of thing. So it'll just be a matter of time. What it does once it gets in the atmosphere is a different thing. It actually has a half-life. It doesn't go away as quick as most people think, but actually being on a body, it doesn't want to stay put. It wants to be a gas.
Okay. So basically, in cases like this where we get they'll get them out of the car, remove them to hopefully a well-ventilated area, decon them with soap and water, or if nothing else, just lots of water for 5 minutes after all their clothes are off.
15 minutes.
15 minutes if we can.
Yeah.
And then hopefully at that point, risks. Okay, perfect. So basically we can get them washed off hopefully at that point in a well-ventilated environment. By then most of what's on them is gone, and what should be sort of dissipating from them hopefully will be gone. But
that's why we check it with a monitor. And if you're getting readings above 10 parts per million, you can decon them again.
Exactly,
So
exactly. And the key with this is that until they're clean, we probably shouldn't have people. We shouldn't have people that aren't in appropriate respiratory protection around them.
Mm-hmm. Again, the TWA. When I mention TWA, time-weighted average, that's the amount the Ministry of Labor has decided, or not decided. They've done research, and they've determined that that's the amount an average worker can be exposed to 8 hours a day, 5 days a week, with no ill effects. Once you exceed that number, you start getting into some potential impacts. So you'll have to keep it below that magic number.
Okay. So a few more questions. How long does the patient need to be ventilated to clear lungs before non-SCBA can intubate or bag the medic? The patient. Well, this was an interesting discussion. I've actually had this discussion with some of the hazmat physicians in the U.S. because that was a question that came up, was, you know, what protection does a medic or a physician need to intubate a patient? And the general thought, though it's never been studied, and obviously it's not likely to be studied, is that if either the patient is spontaneously ventilating themselves for a period of a couple of minutes or longer that it's going to take for decon and appropriate decon, or if they've been ventilated with a BVM for a couple of minutes, the likelihood that there is any persistent gas in their lungs after a couple of tidal volume ventilations is low. I don't know. I don't know, Chris. You've got any other thoughts on that
No,
one? I mean, it's
the best way I would think to check is ask somebody doing the bag valve mask, having a 4-gas monitor near the exhalation. When the H2S stops coming out, you know you're good.
You know you're good, exactly. And hopefully, when you intubate, you know, or if you're at the point of intubating, it's been after either some spontaneous or ventilation for a period of time. And it shouldn't be a major risk to the responder at that point. Is fire decon 100% effective to the point where paramedic in uniform and equipment is sufficient? Yes. Ideally,
check the thermometer.
Exactly. Ideally, that's exactly what we're going for here. Is that they, you know, for paramedics, you're not going to have the equipment that you would otherwise need, like fire, with appropriate sort of SCBA. So ideally, and actually, they should be fully deconned before you're transporting the patient, because you don't want to put yourself at risk. And unfortunately, there are cases where this has happened in Ontario, not necessarily regarding hydrogen sulfide, but chemical exposures that, for whatever reason, didn't get deconned at scene, and we all know different stories of this. Which then put responders at risk and had responders getting sick from it. So
up until the point where the person has been decontaminated, as paramedics, we're probably not going to have a whole lot of involvement. But what you can do is you could work with the fire department. You know, you can provide them with equipment and instructions on beginning treatment of the patient up until they're safe to handle on your own. Whether that means you know, giving the bag valve mask and oxygen, or what have you, whatever treatment you think would be necessary, you could probably facilitate that through the fire department, who have the proper protection to be next to this person.
Yeah, that's a good question for Chris here. Does the time of year, basically the climate, change any of the properties of how H2S would act? I think
I know temperature changes vapor pressure, which the colder the temperature, the less it will want to become a gas, but I have to double check on that, but I'm pretty sure to get the temperatures down to where the gas wouldn't be a problem for us, we're getting into cryogenic vapor,
yeah.
And it's really cold. I haven't seen a winter like that around here in at least 20 years.
All right, next question. If you strongly suspect H2S, would a base hospital patch be considered for pronouncement without patient contact? I don't think that you would be able to pronounce a patient without patient contact. You know, at that point, you still have to go through the hazmat piece, get the patient appropriately deconned, and then assess the patient at that point before you would be able to patch for a pronouncement. Well, we're definitely drawing lots of questions, which is great. It means we've got a good topic, and hopefully we're answering some of your questions. We'll go through a couple more questions here now, then we'll touch on a few more things that we want to touch on, and then we'll answer any further questions at that point. What else do we have? In rural settings, would orange be of any additional benefit? Tough question. I think that very much depends on patient considerations and patient factors. You know, in a patient that is alive despite exposure and needs to be transported to a definitive care, I think that there is at least the potential there, but I guess it depends on how long to definitive care. And we'll talk a bit about some of the treatments. The medications that would be used to treat these patients are not readily available. A lot of hospitals and a lot of smaller emerges may not actually have the medications, especially things like sodium nitrite, where it's really only available by special access procurement kind of paperwork. So there may be some benefits there, but I think that's going to be very much on a case-by-case basis.
I think, too, on a lot of these calls, they're not going to go quickly. You're going to get there, and if you determine that you are going to be able to treat this patient, you're going to be a while waiting for decontamination. So I would suggest it's probably not a bad idea to at least notify Orange and give them the option of responding.
Yeah, good call. Great thought, Josh. Yeah, and that's someone brought up the point that, not all H2S is related to suicides, and it certainly is seen in industry like petroleum, which we have enough of that around here, as well as agriculture settings.
Water treatment plants also?
Water treatment plants, so there's plenty of those around. So yeah, there certainly are lots of other exposure places for this, and not just the intentional suicide. So until the patient is considered clean enough for EMS, how far away should EMS remain? I think I would pass that off to Chris and Josh, but I would guess that your emerge response, and that's a great thought, Chris, is the emerge response guide or emergency responders guide does talk about safe distances. I think it's 117. 117, yeah. I'm not sure. I presume most fire response will have a ERG.
The better. Yes, they should. Yeah, and this is the book. This is the book to get you through the first part of a hazmat incident. And let's not forget, this is a hazmat incident, so go by the book. You can modify your zones once you get more information, but start off the bat with this.
And our ambulances as well. I'm not sure about all the other services, but we do carry those in our vehicles as well. So there is good information in there if you happen to know what chemical you're going to be dealing with.
And Chris has already touched a bit on the question here, which is what is the risk to responders based on the different volumes or concentrations of hydrogen sulfide inhaled. I mean, it depends on the concentration and it depends on the exposure, both the concentration as well as how long you're exposed to it. But ideally, from an EMS perspective, you shouldn't really be exposed to it. You should hopefully, if you can, recognize it and remove yourself from the situation until fire has been able to clear the scene and decon the patient.
And that's really the key for EMS is once you recognize this, it's time to get back and stay out of the way basically until the patient's been decontaminated, because there's really not a whole lot we can do other than expose ourselves to it. And then you're not going to be helping the patient. In fact, you're going to end up endangering even more responders. So that's the most important thing for us is to stay back and just kind of monitor the situation until we've been given a green light by fire after the person's been decontaminated.
Excellent. Well, these are great questions. I think this is the most questions I've ever received on a webinar-based thing, so that's good. It means we're generating discussion within our groups to talk about these things and try and come up with good response plans so people aren't getting hurt. I guess moving right along, we've now gone from recognition, scene safety. We've talked about the PPE and appropriate PPE. We've talked about decon for the patients. The last is talk a bit about transport and sort of management on transport, and we can talk a bit about hospital-based stuff if we feel there's a need. So, I mean, Josh, from a transport perspective, where do things...
So, basically, until the person is decontaminated and we're confident of that, transport's likely not going to occur because the real goal is staying on scene until they are decontaminated. And once they have been, I think it's safe for us to treat them as any other patient. In terms of getting them to the hospital, I guess it probably would be a good idea after the fact to do a thorough cleaning of the vehicle, and probably even if you have the availability to have fire run their monitor through your vehicle. I mean, I suppose, in a case like this, it might not even be a bad idea to have at least one member of the fire department go with you with their monitor so that you can keep your eyes on those levels. I think once you've made the decision that you're going to transport, that's going to be based on the fact that there's very little risk at this point, and that you're not going to be concerned about this gas becoming a problem again.
Mm-hmm. And that's a great thought, Josh, is to bring fire along with one of their monitors so that you can make sure, because all of a sudden you're taking a patient who's been in an open space with good ventilation, putting them in a enclosed space with 1 or 2 or 3 other individuals. So that's actually a really good thought, is to keep people safe and sort of remembering the whole idea of scene safety and then keeping yourself safe and not producing more patients. Yeah, and then essentially management from an EMS perspective on transport is 100% oxygen plus or minus an IV access if applicable and available. And then in hospital, really the management is continued with 100% O2. There is some discussion of the treatment for hyperbarics, but it depends on availability and distance and stuff. And then medical management-wise is based on, or around trying to remove that the hydrogen sulfide from the cytochrome oxidase. And so there's a couple of different possibilities. One is more the old school response, which we used to use in the Lilly kits for cyanide because they work similarly, is sodium nitrite or amyl nitrate. Now, amyl nitrate's not available in Canada anymore, so we don't have the pearls anymore. Sodium nitrite is available, but only under special access. Basically what that does is it produces met hemoglobin, which has a higher affinity for the hydrogen sulfide, so it actually pulls it off that cytochrome oxidase and allows you to produce, or allows the cytochrome oxidase to start working again, essentially. The other thing that is available and is more readily available is hydroxycobalamin, which is one of the new treatments for cyanide toxicity. There is some case reports and some small bench type studies that have suggested that it probably would work in hydrogen sulfide as well, given the similarities of the compounds. And it basically works by forming a complex with H2S so that it is easily detoxified by the body. Yeah, and then other than that, it's supportive care. So, I mean, I think we've been online now for about 40 minutes. We've had lots of great questions, which is great, and I'm really glad that we've been able to do that. I want to thank Josh and Chris for coming down here today so that we can actually talk about this and talk about scene safety and responder safety and management. We'll open it up now for any other questions that may come in. All right, well, there's a good question here for regarding sort of decon, and I'll sort of pass this off to Chris and we'll talk a bit about it. Is there a safe decon time if fire doesn't have a gas monitor? So I guess how long do these people need to be deconned if you're not able to monitor the H2S concentrations?
It got me on that one. Right?
Yeah.
Again, the monitor, you want to make sure basically how long you're done. If you've done a good job. Again, I'd have to look up on an MSD sheet for, usually they say 15 minutes, flushing 15 minutes.
Yeah.
I guess without a monitor, Chris, there's no guarantees.
There's no guarantees. That's what you're, you're following somebody's best guess. There's all those other variables that need to be taken into account. So the best way is to check your work with an air monitor. Exactly,
and I think that's exactly the answer. Is hopefully they do have one. If they don't have one or it's not working, then you're working on best guesses. You're working on best guesses, which may or may not be what you've got to do. But certainly, if you look at the literature on decon and general sort of gross decon with water, most people would say 6 minutes to 15 minutes, and more is better. So. Right. You want to make sure that they're well out of the environment. You're in a well-ventilated environment. Get lots of water on them.
Yeah, you're not going to rinse them off in the car. You're going to take them with the car to a safe area, disrobe them, get the clothes off, isolate that, soap and water, get them cleaned off, and check. The best thing to do is check. If you get a hazmat team responding, they're going to probably check for corrosives left over on the skin too, because that's what they're using soap and water for. So they'll take some pH paper and maybe just dab a couple places on the skin. See if you get the pH paper change color. If it does, they go back and scrub it again.
Keep scrubbing until they're clean.
Yeah.
Excellent. More directed towards the emerge, specific precautions that the ED has to perform before having the patient arrive. Ideally, no. I mean, once again, this comes back to appropriate patient decon and transport. They shouldn't be coming to your department until they've been washed off and safe to be put in the back of an ambulance with paramedics and transported to your hospital. So really, no, at that point, they should be safe to come into your hospital just like they're safe to be in the back of the ambulance. But as with all things, you want to confirm that that's been done before.
Again, like Josh mentioned, I would, if you can get the monitor going on with the ambulance, that would be great.
This maybe
just to be sure.
Maybe is an overgeneralization, but as a paramedic, you're not going to let somebody into the back of your ambulance that has a knife on it. You're going to want the police to check that and give you their guarantee that, you know, that this person has been secured. This gas is no different. It's just as lethal, and you wouldn't want to get that person in the back of your truck, which is an enclosed space, without being very certain that the gas is no longer a threat to you or your partner or anybody else.
Mm-hmm. And I think that's while it is a generalization, it's exactly that. You don't want to become a patient yourself in these situations.
So Mike, I'll jump in.
Do you have any other?
Sorry, Mike. I'll jump in and see if there's anyone else who has any questions that they'd like to ask live. So just a reminder, if you do have a microphone on your computer and you'd like to ask a question live, click on the little hand icon on the top left-hand corner of the control panel, and I'll be able to see that you have your hand up, and then I can unmute you and you can ask your question live. The chat box or the question box is still open if you'd like to type any, and so we'll just take the last few minutes to answer any last-minute questions. I do have one for you, Mike. As a PCP, might a patient who's been exposed to hydrogen sulfide qualify for a medical tour?
Medical tour. That's a good question, Steph. I think the safe answer or my concern with sort of a tour in this setting is that it is a toxin-related event. So it's not purely just a straight-up medical cardiac arrest. Recognizing that, you know, even when we do transport some of these patients who may or may not have a true medical cardiac arrest, that outcomes are still poor, there's at least the potential that you may want to try to intervene if you can. So personally, I don't think that I would want to do a medical cardiac arrest tour in this setting.
I think in terms of education, Mike, I do agree with you. Typically, the medical tour is reserved for patients who are VSA due to cardiac event. Now, again, that's typical, and we've taught otherwise in the past, but I do agree with your answer from an educational standpoint. Are there any other questions out there that anyone would like to ask live? I don't see any hands up at this time. Okay, and so with that, there are no questions left. I'd like to thank Mike, Josh, and Chris again for a very informative presentation. And if I could ask the people who were listening live, send me an email if you can. Let me know what you thought about the new sort of podcast radio chat format. It's definitely driven some discussion, and we've had a ton of questions, probably the most we've ever had during a webinar, so that's been fantastic. And then so looking forward, we do have another webinar, more of a traditional webinar, on April 26th at 9:30 a.m., and we're going to talk about stress in EMS. Sort of a review of an abstract that was written by some of our colleagues here at the Base Hospital program. And we'll talk about that stress in EMS, how it affects you, and who can you sort of go to if you do encounter some stress related to the job. And then in May, we're going to talk about stroke. So we haven't done a stroke webinar in a while, so we thought a good review of that would be great. And once again, thank you to our panel, and thank you to everyone for attending, and we'll see you at our next webinar. Have a great day, guys.